Basically, the most important problem I see in terms of diagnosing inflammatory myopathies is the fact that we can miss them, and those are treatable conditions. So the first part of my talk, that is expected to be on Monday, is basically to make clinicians aware of this condition first and being able to differentiate it with the non-treatable condition. I have in mind one example, which is also part of the inflammatory myopathies, is the sporadic inclusion body myositis, so IBM. This one is non-treatable, while the other inflammatory neuropathies are treatable with immunosuppressive drug. So dividing this and making the difference between those two is really important. You need to start first with the anamnesis, that's really important, and then the clinical examination is really important as well. For the sporadic IBM, basically there is like a key clinical features such as finger flexors and quadriceps weakness. And if you spot that in the patient, you can even do the diagnosis like that without requiring any other MRI or electron myography, etc. On the other hand, with the inflammatory myopathies that are treatable, it's more like a proximal weakness that is usually symmetric with high CK levels. So, of course, you need then to use additional diagnostic tools such as MRI, antibodies testing, and EMG, and eventually muscle biopsy as well, to be sure of your diagnosis and to separate these entities and to be sure that you are treating inflammatory myopathies.